Good evening, everyone, and welcome to Mahamala Case Discussion Series. And for today's session, we have Dr. Khandelwal. She is an assistant professor in head and neck oncology at Tata Memorial Center, Mumbai. And she will be presenting on management of parotid neoplasms in modern era, from anatomy to decision making. So, welcome, Kirti.
Thank you, sir. Shall I start my screen sharing?
Yeah, please start. We can see your screen.
Okay. So screen is visible, sir?
Yes, it is visible.
Okay. So good evening, everyone. I'm Dr. Khandelwal, assistant professor in head and neck oncology at Tata Memorial Hospital, Mumbai. I would like to thank the organizers for giving me the opportunity to present on management of parotid neoplasms in modern era, from anatomy to decision making. So the parotid gland is located within the parotid space, entrapped within the investing layers of the deep cervical fascia. Its development begins in the 7th week of the gestation as an outpouching from the oral ectoderm into the surrounding mesoderm. This initial bud, development starts as an initial bud, it ramifies and then canalizes to form the tubuloacinar system. The parotid and large grows posteriorly while the facial nerve is developing anteriorly. So as the development progresses, the gland eventually envelops the proximal extratemporal portion of the facial nerve and its branches. The encapsulation of the parotid gland occurs after the development of the neck lymph nodes. So this is the reason why there are presence of the intraparotid lymph nodes. And the first salivary secretion occurs only after birth, which is stimulated by feeding. It's the largest exocrine major salivary gland, majorly serous in consistency. It is inverted pyramid in shape. It is divided into superficial and the deep lobe. And its orientation is like base is the superior part and inverted portion apex is the inferior part. So gland has 3 borders and 4 surfaces. Borders are namely anterior, medial, and the posterior border. And surfaces are the superficial, superior, anteromedial, and the posteromedial surface. The superficial surface is related to the skin, subcutaneous fat, platysma, and the great auricular nerve. The anteromedial surface, which is between the anterior and the medial borders, it is related to the temporomandibular joint, the masseter, and the branches of the facial nerve, along with the medial pterygoid muscle. The posteromedial border is between the posterior border and the medial border, the posteromedial surface. It is related with the mastoid process, the sternocleidomastoid muscle, and the posterior belly of the digastric. So from superior to deep, there are structures within the parotid gland. So facial nerve is the superior most, superficial most, followed by the retromandibular vein and the external carotid, which is the deepest. So all these structures supply the gland as well and also run within this parotid gland. The accessory parotid gland was first described by the Frommer. It is a separate salivary gland tissue, which is at a distance of around 5 to 10 millimeter from the main parotid gland. And it is located along the duct of the parotid gland. The parotid duct pierces the buccinator muscle to enter the oral cavity at the upper second molar. So along the Stenson's duct, this accessory parotid gland tissue is located. It has a prevalence of around 30%, and the accessory parotid gland tumors comprises 1 to 8% of the parotid tumors. The rate of the malignancy in the accessory parotid gland tumors is as high as 50%, and they classically present as a mid-cheek swelling and are a potential source of tumor recurrence if it has been left behind. So the mid-cheek swelling is best approached with a facelift incision so that the scar is hidden. classification of parotid is divided into the pathological classification of the tumors, and one is the surgical classification of the surgeries. So first we'll discuss a little about the pathological classification because it has some new entities which we need to discuss. So WHO classification dates back to 1972, and it has evolved over time from purely histological classification to immunohistochemistry to gene fusions and molecular alterations. But by the time we learn the new classification, it is already retro. And as a surgeon, it is really a daunting task to remember all these pathologies. But I'll try to make it simple. So we are at WHO 5th edition of 2022. Interestingly, the number of pathologies has remained constant, steady at 39 pathologies for the last three WHO classification. So there are a lot of additions, deletions, reorganizations, and even renaming of the same pathologies. Currently, there are 4 groups: non-neoplastic epithelial, benign and malignant epithelial, and mesenchymal tumors. So why are we discussing these new entities? Because it is important to diagnose them for the precise prognostication, recurrence rate, risk. It has impact in decision making, extent of surgery, neck dissection. Also, it helps to decide the adjuvant therapy and the follow-up strategy. And these new entities are based on the specific molecular targets. So knowing those targets is a way forward. And in salivary gland, as we know, we have a validated grading system for a very few pathologies. And these so knowing the individual behavior of tumor becomes important. And low-grade carcinomas, even though they are low-grade, but some of them might exhibit aggressive features like perineural invasion, and they have a potential for the high-grade transformation. The pathologies are so interwoven and so closely related that we sometimes tend to misdiagnose them. So changes in the benign epithelial group, we'll not go into this very busy slide. The only thing we'll focus on the new entities which has added, which is in mainly the canalicular adenoma group. So 4 entities have been added in the benign pathologies, and all these pathologies we will discuss a little bit because they are more commonly in the parotid gland. So they are grouped together, but they are still diverse. Sclerosing polycystic adenoma was initially believed to be reactive or inflammatory, but now is considered as a benign neoplasm. It is a very rare, slow-growing, painless tumor with a male predominance, and has among the canalicular adenomas, it is the most aggressive, has up to 30% of the local recurrence, has the its special own markers for the IHC stain, and also mutations of the PI3 kinase pathway. Keratocystoma, it is again benign cystic neoplasm of the salivary gland duct. It also occurs majorly in the parotid. There are no reported recurrences till date, but it has it does not has any necrosis invasion, so it is not a malignant tumor, but yeah, it is a benign tumor. Intercalated duct adenoma falls under the spectrum of the intercalated duct lesion, more commonly occurring in the parotid. Small unifocal tumor, good prognosis, no recurrences, and specific G mutations. Striated duct adenoma is a rare encapsulated unilayer ductal tumor of the parotid gland with the IDH2 classic mutation, which differentiates and makes it unique. There are no recurrences or distant metastasis, and surgical excision with negative margins is a mainstay for all these pathologies. So shifting grades from the salivary gland malignancy from benign to malignant. In the malignant, so as we can see in the latest edition, the majority of the grouping, regrouping, everything has been done in the adenocarcinoma, not otherwise specified group. So we can say that there has been a lot of decluttering happening in this adenocarcinoma, not otherwise specified group. So mucinous adenocarcinoma, which lost its separate identity, has been revived, and it has been given a separate entity in the adenocarcinoma group. The 2 new entities which have been included are the microsecretory carcinoma and the sclerosing microcystic adenocarcinoma. So these are majorly in the minor salivary gland. So we will not discuss much about them, but they are low-grade tumors. And oncocytic carcinoma and poorly differentiated carcinoma used to be a separate entity, but they have lost their separate identity in the present classification. And they have been reclassified into salivary gland carcinoma, not otherwise specified, and emerging entities. So the new entities which I was talking of are majorly in the minor salivary gland. Only one thing I will want to discuss, that microsecretory adenocarcinoma is a new entity because it has a specific gene fusion. And sclerosing microcystic adenocarcinoma is important to know because it has perineural invasion. So very few tumors have perineural invasion. That is why we can just know about it. So coming to the 9th edition of the salivary gland TNM classification. So there has been a lot of change in the present classification. TX, I will just enumerate. TX is a primary tumor, cannot be assessed. T0 when there is no evidence of primary tumor. CIS is the carcinoma in situ. T1 is less than 2 centimeter without extra parenchymal extension. T2 is more than 2 but less than 4 centimeter without extra parenchymal extension. T3 is more than 4 centimeter or gross extra parenchymal extension or adjacent mucosal soft tissue extension beyond site without structural involvement. And this extra parenchymal extension has to be clinical and macroscopic. Microscopic alone is not the criteria because it is a clinical staging. T4A is tumor invading adjacent structures like skin, bone, cartilage, solid organ, parenchyma, esophagus, trachea, and or any named nerve. So this solid organ, parenchyma, esophagus, trachea, cartilage, this was not included in the previous classification. And the destruction of the sinus bones or the erosion of the just cortical bone is not a criteria for the bone involvement to classify it as under T4A. T4B is invasion beyond the adjacent structures, encasement of the carotid artery, skull invasion, except the nasopharynx. So spinal column involvement, intracranial, orbital involvement, all these were not included in the previous classification, which have been included. So it's a more detailed T classification for the parotid, for the salivary gland neoplasms, and there has been change entirely in the nodal staging as well. So it was a classical oral cavity nodal staging or other head and neck nodal staging which used to be followed, but now it has been, N1 is 1 to 3 ipsilateral lymph nodes without unequivocal imaging detected or clinical extranodal extension, and N2 is metastasis in more than 3 lymph nodes or imaging detected or clinical extranodal extension. So the N3 is not there, N2A, B, all these are not there. And midline nodes are classified under ipsilateral nodes. Distant metastasis M0, M1. So thankfully, a lot of pathologies in the non-epithelial have been removed. Hemangioma, lipoma, all these are not there. So we have only mesenchymal tumors and non-neoplastic epithelial lesions. We have the lymphoepithelial ciliadenitis and nodular oncocytic adenosis. This is just to complete the new entities. So now coming to the parotid gland surgical classification. It is based on the fasciovenous plane of the patty, which divides into the larger superficial lobe and the smaller deep lobe. This division is not embryonal in origin and has led to considerable variation in nomenclature of the parotidectomies. So for benign tumors, we have come from less to more. We were doing enucleation before, more of extracapsular dissection, and now moving towards the superficial parotidectomy. And for malignant tumors, because there were a lot of recurrences being noted in the benign or small tumors. So that is why there's a shift towards the surgical spectrum. For malignant tumors, it has been a little on the contrary side, meaning that radical parotidectomy, we are more conservative for the facial nerve, preserving the facial nerve as far as possible. So the functional outcome, to maintain the functional outcome for malignant tumors, we are trying to preserve the facial nerve as far as possible. So European Salivary Gland Society has classified parotid gland into 5 levels. So superficial and deep is below and above, above and below the facial nerve, and superior So level 1 is superior, superficial. Level 2 is superficial and inferior, that is below the lower trunk. Superficial lobe, but below the lower trunk. Deep inferior is the third level, which is deep and below the inferior division, and deep superior is level 4 and accessory is level 5. A parotidectomy is defined as a procedure in which at least one level is removed with dissection of the main trunk and at least one of its major branches. So two conditions are needed for saying a procedure as parotidectomy according to the European classification. Extracapsular dissection, at least one condition, no facial nerve dissection performed, or less than one level removed. So when that is a definition for the extracapsular dissection. And non parotid structures are denoted using specific abbreviations. So procedures are named in the following order. So depending on the type of surgery, parotidectomy or ECD for extracapsular dissection, R meaning right, left, L, and both sides. So side has to be specified, followed by the levels removed, which has to be in ascending order. For example, 1, 2, 3, 1, 2, 4, 2, 2, 4, whatever. And non-glandular structures removed have to be the last one. So this is to maintain an effort to maintain the uniformity across the globe. So extracapsular dissection versus superficial parotidectomy. All these procedures are done mainly for the benign tumors or the low-grade T1, T2 tumors. So when we compare these two, systematic reviews reveal similar recurrence rate, but extracapsular dissection does show some lower temporary facial palsy rate, and auricular sensory recovery rate is better salivary function and less operative time. But all this systematic review, most of them are the retrospective studies, and where size has not been taken into account. There the follow-up is not very long, nomenclature is varied, pre-op palsies is not reported, partial superficial parotidectomy procedures have also been included, and these are mainly retrospective. So there is no consensus for gold standard, but yes, both of the procedures can be done according to the case-to-case basis. Facial nerve consists of intracranial, intracanalicular, intratemporal, and extratemporal segments. Several classifications describe its extratemporal branching patterns. So mainly it's the upper division and the lower division. Upper division being the temporal zygomatic, and lower division giving buccal, marginal, and the cervical branches. So extratemporal facial branching patterns first was given by Davis et al., and the most commonly widely used is Katz and Catalano classification, wherein type 1 is a straight pattern. Type 2 is you have the zygomatic loop connection with the zygomatic branches. Type 3, when there are connections with the buccal branches, so buccal loop, which is the most common. And type 4 is having multiple loops between different branches. And type 5 is when there are two main trunks. So various surgical landmarks we need to identify these facial nerves during the parotid surgery. Tympanomastoid suture, mastoid, styloid, many of them have been described, but the most reliable surgically are the tragal pointer and the posterior belly of digastric when it meets the posterior, this sternocleidomastoid muscle. So tragal pointer, the facial nerve lies 1 to 1.5 centimeter deep and inferior to the tragal pointer, and it is 4 to 5 mm superior to the posterior belly of digastric, but the depth is at a similar level. Facial nerve injury can be due to multiple factors: dissection, transection, laceration, retraction, cautery, or suction trauma, ischemia, or in few cases, when we have to sacrifice a nerve. Facial nerve palsy post-parotid surgery, temporary palsy rates vary from 14 to 65%, most of which is marginal mandibular palsy, and more than 95% of the cases recover by 6 months. So permanent palsy rates are vary from 0 to 8%. So malignancy, recurrence, deep lobe involvement, and old age has also been identified as risk factors for the post-op facial palsy. pre of facial palsy, 15 to 20% of the patients do present with pre of facial weakness, which is a strong negative predictor even for the recurrence because it denotes the aggressiveness. And it is a deciding factor for facial nerve sacrifice if facial nerve involvement is found intraoperatively. And also when we have a pre of facial nerve palsy, we can plan the anastomosis and reconstruction prior. So it has an implication. But when pre of facial nerve function is intact, so what to do in that case when you find a tumor very close abutting or involving the facial nerve? So we have evidence for which says that sacrificing facial nerve does not reduce the margin positivity rate, neither it improves the survival, and does not obviates the need for the adjuvant therapy as well. So when the nerve function is intact, our inclination should be to preserve the nerve. And if the tumor is abutting, then definitely we have to preserve, try to use micro dissection, magnification, whatever, but try and preserve the nerve. And but if the tumor is involving extensive involvement of tumor in the facial nerve, so that decision is to be based on multiple factors, which can be histology, extent of the involvement, age, and the patient wish. So we have to anticipate that before. So once the injury has happened, there is nothing undoing it. There's no role of intra-op and post-op steroids to reduce the facial palsy rates. Role of adjuncts, we are trying to explore. The meta-analysis have been done, which shows some benefit in reduction of both the transient and permanent palsy rates. But most of it is based on the retrospective data, and only 2 prospective studies have been included, which individually show no difference in the permanent palsy rates at least. But they do tell that severity of the transient palsy is reduced with the nerve monitor. And surgery duration is little less with the intra-op nerve monitor, less of blunt trauma is there. So, yeah. Lymphatic drainage. So lymphatic drainage, there are 2 types of lymph nodes, intraglandular and extraglandular. Intraglandular also we have superficial and the deep group in the superficial and deep lobe respectively. And extraglandular can be subfacial or extrafacial, which is a preauricular lymph nodes. Lymphatic drainage within the parotid gland happens superiorly to inferiorly, and the efferent pathways are infraclavicular pathway, infraclavicular group of lymph nodes draining into the upper jugular, and the pink one which we can see are the main group of the lymph nodes, main pathway, which will be level 2, 3, 4. And when there is deep lobe involvement, they can metastasize to subparotid retropharyngeal lymph nodes, and posterior accessory pathway can be the main pathway at that time. So posterior upper jugular level 5 nodes can harbor metastasis. Intraparotid lymph nodes are important to know to diagnose preoperatively, because sometimes they are not usually the first echelon also. It depends on the tumor location. For example, if a tumor is in the deep lobe, you might not have a intraparotid lymph node, but you will have a lateral neck node metastasis, maybe a posterolateral as well. So intraparotid metastasis is in 1/3 of the patients, and presence of intraparotid metastasis is independent high risk factor for the recurrence. It has 2 to 3 times higher risk of recurrence, and it also influences the extent of the parotidectomy. So involvement of the intraparotid nodes, we might have to do a total conservative parotidectomy and add a neck dissection also. Role of RT in presence of intraparotid nodes is still questionable, but precise imaging, planning, and extensive pathology to report and diagnose these nodes are important. In a clinical N0 patient, nodal metastasis is most commonly in level 2, followed by level 3. It also depends on the histology of the tumor. And in neck node positive cases, nodal metastasis is high at all the levels. So this is a NCDB database around 7,000 patients, which show that neck node metastasis is a negative predictor for recurrence and survival both. And N0 patients have occult metastasis in 8.2% low-grade pathology in low-grade pathology and 30% in high-grade pathology. So in low-grade N0 neck, we might not do a elective neck dissection also. And higher incidence of level 4 and 5 metastasis is there in node positive cases. So for a simple algorithm, low grade T1, T2, CN0 tumors, level 2 to 4 neck dissection can suffice. But if it is a high grade T3, T4 or N positive cases, level 1 to 5 neck dissection has to be done. Am I audible? Hello?
Yes, you're audible.
Okay. So we have to diagnose the pathology pre-operatively is also very important. FNAC is cost-effective, safe, rapid. It has relatively higher rate of non-diagnostic or inadequate samples. They can diagnose between the non-neoplastic and the neoplastic lesions and can have a high accuracy for high-grade carcinomas. But the subtyping of the neoplasm cannot happen. And sometimes benign and low-grade tumors also we can't differentiate. So sensitivity is little less, but it has a good specificity. And for a uniform reporting, we have to follow a Milan system, which categorizes into 6 types, and each category has its own risk of malignancy and even proposed risk of higher grade malignancy. Core biopsy, definitely the architecture is preserved, so has a better sensitivity as well. And all the indications as of now are non-diagnostic entity, lymphomas, ancillary test, means when we want to do a IHC or a molecular study. And complications is not, they are very minimal. Seeding and facial nerve palsy, not much reported complications have been there, even in the meta-analysis. Role of frozen section. So to clarify the diagnosis, which if we don't have pre-operatively, to check the operative margins when we are in doubt, and to take a decision on the nerve or the neck node, neck dissection. So this is a current role of frozen section in parotid tumors. The accuracy and the sensitivity of frozen section is much high as compared to the FNAC. So we have the imaging techniques have improved so much that we have so clear images pre-op to plan our surgery, to decide the treatment for the patient. In parotid tumors, ultrasound is first investigation, but it has an implication in maybe small benign swellings or very small low-grade malignancy. But usually MRI is a preferred investigation. But ultrasound, the FNACs have to be ultrasound guided so that the yield is high. And it is a good investigation to differentiate between the intraglandular versus extraglandular. And ultrasound is also very operator dependent. MRI helps to know about the size, location, the extent of the tumor, the surrounding structure involvement, contralateral parotid salivary gland involvement, evaluation of lymph nodes, perineural spread. All this can be assessed in MRI. So T1 sequences are mainly for when we want to see any, if there's a high signal within the lesion. So it is classically occurs in the Warden's tumor when they have a protein or hematic components within the lesion. T2 is used to compare the signal of the lesion with the normal parotid. So when the signal is high, the grade of the tumor is low. And as the signal decreases, the grade of the tumor increases. So the first picture we can see on the left-hand side is a high signal intensity. So this is a pleomorphic case of pleomorphic adenoma. And as the signal intensity reduces, the third picture, left-hand side disease is of a high-grade malignancy. So higher grade will have low signal. Apparent diffusion coefficient, it is calculated in the diffusion weighted sequence of the MRI, and It happens due to the Brownian motion in the free waters. So less of the apparent diffusion, ADC values represent higher grade tumors. And as we go towards benign, the ADC increases. Just to mention about the perfusion weighted sequence, it is a dynamic sequence measuring signal intensity pixel by pixel over time. So the first we can see it is a ascending graph. So the ascending graph, or when we have a washout of more than 50%, more than 30%, these are usually benign cases. But when there is a descending path, or the washout is less than 30%, it denotes a high grade tumor. CT scan is specifically important when you want to see the bone, the skull base involvement, and also it has a little higher sensitivity for detection of metastatic nodes. But mainly the bone and the skull base involvement we want to see in CT in case of advanced tumors. Comparing the efficacy of the three modalities, so MRI has the highest pooled sensitivity and specificity. And sensitivity of ultrasound is low as compared to CT and MRI, but specificity is comparable. PET scan, the indications of PET scan in parotid tumors are the high-grade histology, recurrent tumors, advanced T and end stage, and when there's a clinical suspicion. So high-grade tumors can have upwards of 50% risk of metastasis. So PET scan is very important in high and even intermediate grade histologies. And because distant metastasis is the function of the histology in parotid gland tumors. And unlike oral cavity, 40 to 50% of the distant metastases are extrapulmonary without pulmonary metastasis. So CECT head, neck, thorax might not suffice in parotid malignancies. Distant metastasis in parotid tumors, the rate of distant metastasis is around 15%. It's a range, but around 15%. Distant metastasis at presentation is around 5 to 6% of the patients, and highest distant medicine is in high-grade histology, salivary duct carcinoma, adenocarcinoma. Adenoid cystic carcinoma has a very peculiar distant metastatic feature, which has slow-growing asymptomatic lung mets for years. So even in presence of lung metastasis, we can plan a curative treatment for those patients. And high-grade histology, advanced T-stage, neck nodal metastasis are risk factors for distant metastasis. And 5-year distant metastasis specific survival is usually 30% when all histologies are taken into account as together. So location and number of metastases matter. So bone metastasis fare worse than the lung metastasis. So lung metastasis has a better survival, and also it is inversely related to the number of metastases. And site, incidence, and prognosis of distant metastasis is histology driven in salivary gland malignancies. Preferred treatment for distant mets is surgery wherever feasible, because those patients who undergo surgery have a higher distant metastatic specific survival. However, we can see that non-surgical and observation don't have much of a difference. So unresectable symptomatic group of patients are those patients where we can think of non-surgical options, chemotherapy or the targeted therapy. Post-op radiotherapy, the indications are high-grade, positive margins, perineural invasion, lymphovascular invasion, lymph node metastasis, T3, T4 tumors, and adenoid cystic carcinoma. Post-op chemoradiation role is not defined. It's not defined outside a clinical trial setting. Thank you.
Thank you, Dr. Kirti. There are some questions in the chat box. Would you like to take them?
Yeah, sure. Actually, just wait, I can't see the...
I'll read out the questions to you. How reliable is frozen section in determining perineural invasion, and should the decision to sacrifice the nerve rely solely on it?
No. So the decision for the sacrificing facial nerve should not rely on the frozen section, because even if the facial nerve preoperatively function, as I said, is intact, and even if we cannot achieve a R0 resection, it's okay to shave off the tumor, because there is enough literature which shows there is no added advantage of sacrificing facial nerve in those cases. And frozen section has a utility for perineural invasion in those cases where facial nerve is not functioning preoperatively and the tumor is involving the facial nerve. Then how much to resect the facial nerve, the decision of the extent of the resection, and subsequently if we are reconstructing in the same setting, so it is important in those cases. Does intraoperative nerve monitoring reduce temporary palsy rates, or does it merely aid in identifying nerves? So there have been sparse literature which shows that temporary palsy rates, the grade of the temporary palsy rates have been reduced. Yeah. And in clinically N0 high-grade parotid carcinomas, would you just do would you justify doing an elective neck dissection or rely on adjuvant therapy alone for occult? So elective neck irradiation is an option, but for high-grade N0, it is advisable to do a neck dissection. Anyways, a patient will receive post-op adjuvant. So as we do in other subsites, in high-grade N0 neck, we should do neck dissection, elective neck dissection.
Dr. Kirti, that was a good comprehensive presentation. We would request you to join our next case discussion and join as an examiner. And now I would like to, yes. And now I would like to go ahead, we would like to go ahead with the case presentation. And today's case presentation will be by Dr. Indrajit Chauhan. He is an MCH resident from RCC Trivandrum. And he is going to present a case on parotid neoplasm. And the moderators for today are Dr. Shaji Thomas. He is a professor in the Department of Head and Neck Surgical Oncology, RCC Trivandrum. Dr. Amit Chiro, he is a professor in Head and Neck Surgical Oncology, AIMS, Delhi. And Dr. Kiran Joshi, she is a senior consultant in Head and Neck Surgical Oncology, Action Cancer Hospital, Delhi. Dr. Indrajit, you may start.
Ma'am, can you stop sharing your PPT?
Yeah, just a minute. So sorry. Is it okay? Have I stopped sharing?
Yes, ma'am. Good evening, everyone. I'll be presenting my case of Mr. X, who is a 43 years old male, caretaker by profession, resident of Malda, West Bengal, presented with swelling below and in front of left ear for 3 years. It was insidious in onset and gradually progressed to present size. There was no history of associated pain, no history of increase in size when chewing. There's no history suggestive of facial nerve palsy in form of asymmetry of face, difficulty in closing the eyes or lacrimation, difficulty in chewing food, any drooling of saliva or stuffiness of nose. There's no history of any other swelling in neck or on the other side of in the parotid area. No history of swelling of scalp or skin of head and neck. There's no history of snoring, voice change, difficulty in swallowing. There's no history of cough, breathlessness, hemoptysis, night sweats, weight loss, or fever. Patient doesn't have any comorbidity. There's no history of previous radiation exposure. There's no history of drug allergy and no history of COVID. He consumes a mixed diet. He had been a BD smoker for last 20 years, 4 BDs per day. Uh, doesn't consume alcohol, no other habits, no change in bladder habits, no significant weight change or normal appetite. There's no family history of cancer, and there's no history of surgery. To summarize my history, my patient, 43 years old male without any known comorbs, presented with painless swelling in left parotid region since last 3 years with no symptoms of facial pulse.
Yes, Indrajit, can you hear me?
Yes, sir, I can hear you, sir.
Why did you specifically ask history of snoring and voice change in parotid swelling?
Sir, deep lobe tumors, if they are involving parapharyngeal space, like anterior parapharyngeal space, then they can basically cause narrowing of the airway leading to snoring. And if there is extension to post-styloid compartment, like if the tumor is large, which is usually rare, but it is possible, then 9, 10th, 11 cranial nerve may be involved, which may lead to dysphagia or narrowing of the airway and hoarseness of voice, sir.
Okay, cranial nerve involvement is usually unusual.
Yes, sir. Unusual, sir. It is unusual, sir.
Okay. Then, is there any difficulty in opening mouths?
There is no difficulty in opening mouth, sir.
Okay. So, what is that? Why is that history important?
Sir, difficulty in mouth, opening mouth means tumor has either involving masticatory muscles, most commonly masseter, or in very advanced cases, it may involve temporomandibular joints, sir, which may cause difficulty in opening mouth, sir.
Did you ask any history of excision of any swelling in the facial region or in the scalp in the past?
Yes, sir. There is no history of any. There is no such history, sir, of excision of. Yes.
Why it's important?
Sir, in tumors like cancers like melanoma or squamous cell carcinoma of the head and neck region, specifically periorbital region, more specifically, there can be lymph nodes in parotid regions.
Most important DD of a parotid swelling is a preauricular lymph node.
Yes, sir. Preauricular lymph node, which may be due
So you have
to
to-
these pathologies, sir.
Okay.
Hello, Indrajit. I'm Dr. Kiran.
Hello, ma'am. Good evening, ma'am.
Yeah, good evening. I just want to ask, you didn't ask the history of trauma.
Ma'am, I asked, I actually forgot to mention, ma'am. There's no history of trauma, ma'am.
And any history of ear discharge or oral purulent discharge?
No, ma'am. There's no history of ear discharge or purulent discharge, ma'am.
Yeah, actually, you didn't mention.
Yes, ma'am. Yes, ma'am. Yes, ma'am. I should have mentioned.
And what about the occupational exposure?
There's no such occupational exposure, ma'am. He works as a caretaker in another person's home. So
Okay.
there's no such. There's no. He's not an industry worker like a rubber or a wood factory or chromium or nickel factory, ma'am.
Just go back to your negative history slide. So, did you ask about the dry eyes history of dry eye, and why it is important?
Ma'am, history of dry eyes is important in ruling out condition like Sjogren's syndrome, ma'am.
Yes.
Where yes, ma'am.
Actually, autoimmune disorders. Autoimmune disorders.
Autoimmune disorders, mainly Sjogren.
Okay. So there is no size variation with the swelling with chewing.
Yes, sir.
Okay.
Is there any history of fluctuation in size?
There's no history of fluctuation in size with eating when eating, sir.
Or with the upper respiratory infection?
No, sir.
What does it imply?
Sir, increase in size with upper respiratory tract infection may imply diagnosis of branchial cysts, which are supposed to flare up with upper respiratory tract infection, and which can occur in the same region, sir.
Any tumor?
With upper respiratory tract infection, sir.
Maybe might not be in this age group, might be in the older. In Wardens, you can also have this type of features
Sure, sir. Sure, sir.
because it have got a lymphoid component, so it can fluctuate in size.
Yes. Yes. Can I proceed further, sir?
Yes, yes.
On general physical examination, patient was well oriented, alert, performance status of ECOG 0. He was moderately built and nourished. Vitals were within normal limit. BMI was 20.5. There's no palatal cyanosis, clubbing edema, or generalized lymphadenopathy. On local examination, there was swelling in left preauricular area. In fact, it was like preauricular in location, but it was inferior to pinna. And skin swelling was normal. There was no facial asymmetry. Jaw movements were normal. On examination, oral cavity, oropharynx, parotid duct was orifice was visualized in a normal position. There was no pus or blood discharge from there, and there was no bulge in oropharynx in tonsillar region, or there was no deviation of uvula. On examination of on the inspection of neck, there was no visible pulsation, dilated vessels, sinuses, fistulae. There was no visible swellings like node. On palpation, single 2 into 2 centimeter non-tender firm swelling with no local rise of temperature. The swelling was lobulated, and it was present in left preauricular area, inferior to tragus, slightly lifting left ear lobule. It was mobile. Skin over swelling was normal, and superiorly it was 5 centimeter from zygoma, inferiorly 2 centimeter from angle of mandible, posteriorly 1 centimeter from mastoid process, and anteriorly 7 centimeters from left oral commissure. Facial nerve examination was normal. There was no significant neck nodes on palpation. Oral cavity oropharyngeal examination was normal. Opposite parotid gland, bilateral submandibular glands were normal. And eye and scalp examination and face skin examination was normal. The lower cranial nerve examination was normal. And on video laryngoscopy, there was no bulge noted in lateral pharyngeal wall. Bilateral vocal cords were mobile. Systemic examination was unremarkable.
Let's go back to your inspectory finding. Inspection. Yes. So the swelling to me looks like more intra-auricular. I can't
Yes, ma'am. Yes, ma'am.
the pre-tragal region. And another thing, while you are mentioning the inspection finding, you have to tell about the extent during the inspection as well as during the palpation.
Okay, ma'am.
And about the mouth opening, you have not told, I guess.
I've told that jaw movements are normal, ma'am. I should have mentioned that mouth opening is adequate, ma'am, and there's no trespass. There's no trespass.
Yeah,
That
you
I
have
should
to
have.
tell in centimeters how much is the mouth
Yes.
opening.
Yes, ma'am. Yes.
And did you do the bimanual examination of parotid?
Uh,
Is that
no, ma'am.
why?
To avoid gag reflex, ma'am, and visibly, like it can be visualized behind anterior tonsillar pillar and as deviation of uvula. So I did not attempt bimanual exam.
Similarly, you should try for a bidigital palpation of the parotid duct also. May not
Yes.
be very significant, especially in calculus diseases or inflammatory conditions. Only when you press, there will be
Yes.
pus discharge.
Yes. Yes.
So for completion's sake, you have to do the bimanual palpation to know whether the deep lobe is enlarged,
Yes,
and the bidigital palpation for the parotid duct.
sir.
When the swelling is obvious in the lateral pharyngeal wall, then you just want to see the extent. Okay, you do
Yes.
not want to, because it is obvious that it is extended to parapharyngeal space
Yes.
involved.
Yes.
So when it is not there, you just want to see by manual examination that whether it is there extending or not.
Okay, ma'am.
So, what is the classical position of a parotid swelling that is described?
Classical position as it lies in parotid space, sir.
It's classically told it's below, behind, and in front of the
Yes.
earlobe.
Yes, below, behind, inferior, sir.
Okay.
Basically inferior and behind, sir, earlobe. Yes.
What is the plane of the swelling?
Plane, sir.
Yes.
Sir, it is lies superficial to the uh, it lies superficial to the masseter muscles.
So,
On clenching of teeth,
those things you didn't mention. So
yes.
ideally you should say the plane of the swelling that's it's superficial to the masseter. How will you
Yes.
check it?
Sir, patient is asked to clench the teeth, sir.
Then
And if it is above the level of masseter, it will become more mobile, sir.
not more mobile, becomes more
Like
more prominent.
more prominent it will become, sir. While if it is below the under the masseter, it will become less prominent on clenching the teeth, sir.
Okay. Then the other is parotid is within the parotid fascia.
Yes.
Okay. How will you stretch the parotid fascia?
Sir, patient is asked to basically we can palpate it, palpate the swelling, sir.
So the plane of the parotid swelling is it is superficial to the masseter and deep to the parotid fascia.
Parotid fascia, sir. Yes.
Okay, so that means you ask the patient to open the mouth. That will stretch the parotid fascia.
Okay, sir.
Okay, then it becomes less prominent. And when
Sir.
you ask the patient to clench the teeth, since it is superficial to the masseter, it becomes more prominent.
More prominent. Yes.
Okay, that's how you exactly find out the plane of the swelling.
Yes.
Okay, in mobility you didn't mention.
Mobile, sir. I've
Okay,
Go to your palpatory finding.
mentioned mobility, sir.
how is its mobility?
It is mobile, sir, in all directions.
It's not. You can't say it's a freely mobile. Parotid swellings are not freely mobile. It's more mobile in the transverse axis.
Yes, sir. Transverse axis.
But it will be restricted its mobility above the zygomatic arch.
Yes.
What is it called?
Sir, it is
That
called
side.
Curtin sign, sir, because parotid fascia is attached to zygomatic arch, because of which we cannot move parotid beyond that area, sir.
Okay, the investing layer of deep cervical fascia,
The cervical fascia, which forms the
parotid capsule.
Yes.
That splits to enclose the parotid gland, and that is attached above to
The superficial lamina is attached above to zygomatic arch.
zygomatic arch. So it cannot be moved above the zygomatic arch.
Yes.
Okay. So then you told
About
the surface.
facial nerve function.
Sir?
What about the facial nerve function?
Facial nerve function is normal, sir.
So, especially in parotid tumors, if you are suspecting some malignancy, then it's better to tell about the facial nerve function, both the upper and the lower trunk.
Yes.
It's not necessary to involve the trunk, main trunk. It may involve the branches separately.
Yes.
Similarly, you told the surface is lobulated. What does it mean?
Sir, it is not smooth or like it is seen in cystic lesions, sir.
Okay. So, what does it usually lobulated parotid swellings? What is it?
Usually, it will be suggestive of neoplasm, sir.
Usually, slow-growing neoplasms like pleomorphic adenoma. When it becomes larger size, the surface will be lobulated.
Yes.
Okay. It's non-tender also.
Yes, non-tender.
Okay, then can you summarize your findings?
Just 1 second. You didn't mention about ear examination. Did you check the ear? You said the lobule was raised. Was it inside the ear canal?
Ma'am, I did not do otoscopy, but otherwise, ear was normal. There was no ear discharge, ma'am.
No, no, no. It is not related only to ear discharge. You have to examine ear also.
Yes, ma'am.
For parotid, you have to examine oral cavity, oropharynx, vocal cord status for the cranial nerve, ear and neck, as well as opposite side of parotid gland and
Yes.
cutaneous, the neck and scalp skin.
Yes. Yes. Shall I proceed ahead, ma'am?
Summarize your findings and
To summarize, my patient who present a smoker without comorbidity with painless swelling in left parotid lesion since last 3 years with no symptoms of palsy on examination was found to have 2 into 2 centimeter non-tender firm mobile lobulated swelling in left preauricular area with the restricted mobility with no involvement of overlying skin with normal oral cavity or oropharyngeal examination, no features of facial nerve weakness, and no cervical lymphadenopathies.
So what are your DDs after the history and the clinical examination?
Sir, my first DD will be benign parotid neoplasm. Second will be intraparotid lymph node, sir.
Okay.
so Indrajit, why did you say it's benign? What are the points in favor of benign parotid swelling?
Sir, it is painless, slowly progressive. There is history of 3 years and the size is still 2 into 2 centimeter. There is no involvement of facial nerve, sir. There is no evidence of fixity, sir. And age-wise also, the patient is younger age group, sir. And sir, there was no lymph nodes, sir.
Okay. And benign swellings are the most common swellings in parotid. There is a
Yes, sir.
one of the-
Benign being most common, around 80%, sir. So that is one more reason in favor of the benign parotid neoplasms.
Can it be a low-grade carcinoma?
It could be, sir. It could still be a low-grade carcinoma, but since history is of 3 years with little increase in size, sir.
Okay, so everything points towards a benign etiology.
Yes.
You have said about smoker. What is the what do you want to infer with this?
Sir, smoking is related to Warden's tumor in the parotid, sir. It is more commonly seen in smoker. Warden tumors is more commonly seen in smokers, sir.
Is this the age group is fitting in the Warden's tumor?
Age group, no, sir. It is seen in elderly, usually 60 to 70 years of age.
And consistency also usually cystic, soft.
Cystic, it will be cystic, yes.
So it doesn't
It
clinically
will
or
usually involve the tail of parotid, sir.
okay, it doesn't fit into any of the characters of Warthin's tumor.
So if you have to say the benign parotid tumors, then what are the some benign tumors you can think of?
Sir, benign tumors are pleomorphic adenoma, sir. And then most common is pleomorphic adenoma. Then second most common is Warden's tumor, sir. Then there are cystadenomas, sir. And then other tumors may be related to soft tissue, sir, like lipomas or schwannomas, sir.
Okay.
How many lipomas you have seen in
Lipoma is
It has
not
been-
in the
It has been described in classifications, ma'am. So that's why.
very rare?
Yes.
schwannoma of the facial
I'm
nerve.
yet
We
to see
rarely
any.
see,
Yes.
but you can't say clinically. Clinically,
Yes.
you can say only it's a benign tumor, most probably a mixed parotid tumor or a pleomorphic adenoma.
Yes.
It's good that you have put the DD of schwannoma, because schwannoma, if it turns out to be in a younger patient in this location,
Yes.
then they can come with a normal patient nerve, and without any, all the times they go surgery without even FNAC, then you're going to be into trouble.
Sir.
So schwannoma, if you are thinking in the DD, then it's good.
Sir.
Yes, Indrajit, anything else? Or you can, how will you proceed further if no further?
Sir, this patient, like I'll proceed ahead further with the ultrasound of the parotid region, sir, and neck, bilateral parotid region and neck, sir, which is usually the first investigation, and ultrasound guided FNAC will be done, sir. With an aim of knowing the location of the lesion, sir, and characteristic of the lesion, whether it is involving superficial or deep lobe, whether neck nodes are involved, sir, whether it is benign or inflammatory. So those information can be obtained with the ultrasound, sir.
Ultrasound usually won't give much of it. Only thing you can see it's a parotid swelling, and the important features you want you may not get in a. Maybe it will guide you for the FNAC.
Yes.
Otherwise, usually most of the surgeons won't proceed with an ultrasound. Maybe an initial investigation.
Yes, sir. It is usually the initial investigation which is performed, sir. So like this patient came to us with ultrasound from done from outside, sir. So
okay, it can differentiate between a solid and cystic swelling. You can locate the tumor. It will guide you FNAC. But regarding the facial nerve or deep lobe, or I don't know, and a lot of subjective variability is also there in ultrasound.
yes, yes,
So if the swelling is located in the tail where you can palpate the extent,
yes,
you can hold the swelling, then maybe ultrasound. Otherwise, MRI is best to see the location as well as extent, because sometimes you will see in ultrasound the size they must have written is small, but intraoperatively you will see that it is going in between the facial nerve into the deep lobe. So
yes,
if it is only limited to tail, very small swelling, 1 or 2 centimeter, then might be ultrasound, otherwise MRI, contrast MRI.
yes,
Ultrasound as doing the FNAC for the guided FNAC.
yes,
Can do ultrasound guided FNAC. Otherwise, ultrasound based on ultrasound and planning the surgery is difficult.
So, what is the finding ultrasound?
Sir, as per the ultrasound, it was 2.9 into 1 centimeter hypoechoic lesion in left parotid gland, superficial lobe of the left parotid gland. No significant lymph nodes, sir.
How they have mentioned superficial lobe in the superficial lobe? Have they mentioned this in the report?
Yes, ma'am. They written like that, ma'am.
Yes, ultrasound done. Then what did they do?
Sir, my investigation of choice will be contrast enhanced MRI, the parotid region and neck, sir. Basically, head and neck, sir.
So, how do you between contrast between MRI and CT, CCT? How
Yes.
will you choose your patient?
Sir, MRI being like it will delineate the soft tissues better, so it is investigation of choice. And in MRI, we can also get to know features like perineal invasion and skull base or intracranial invasion or extension to areas like nasopharynx, not in parotid but other salivary gland, minor salivary gland tumors. Uh, So CT is done only when there is suspicion of bony involvement, sir. Like if there is suspicion of involvement of mandible, sir, or involvement of external auditory canal, or like if a tumor is reaching till skull base, then to rule out intracranial extension. Not to rule out intracranial, for that MRI is better, sir. But CT is required for bony erosion.
Okay.
Yes.
Generally for limited parotid swellings, you take MRI, contrast
Yes.
MRI.
Yes.
Okay, you have the image.
Yes, sir. I have the our PACS image, sir. Sir, this is a coronal MRI image of head and neck region, sir, in which I'm going from anterior to posterior, sir. And on left side, we can see a hypointense lesion near the inferior pole of the parotid, sir. It is infraauricular in location, sir. And it doesn't seem to be involving the deep lobe, sir.
I will suggest you first take axial scan
Yes, ma'am.
and then show the coronal.
Okay.
And in relation to
Even I don't have axial. Yes, ma'am.
Okay. Yes.
now you can say that it is in the superficial because you can see the RMD, recommending
Yes.
the
Why
Yes.
do you say it's in the superficial lobe?
Sir, we can see the plane of like fasciovenous plane, sir. We can say, sir, beneath the swelling.
Okay,
Medial.
so it is
And secondly, sir, the oropharyngeal, like it is not involving parapharyngeal space, also, sir.
it's purely superficial lobe, limited to
Yes.
superficial.
So you have to tell which imaging you are showing, like this is the T1. Then you
Yes.
have to say what cuts, this is the axial.
Yes,
And
ma'am.
then you have to say that from craniocaudally you are going. Like that
Yes.
you have to present in the exam. And then you have to describe the extent of the swelling. And then you have to tell whether it is in superficial or deep lobe
Yes, ma'am.
and reaching to the surface of the gland.
Ma'am. It doesn't seem to be involving skin or bone. It is limited to the parotid tissue only.
Okay. Yes, no cervical lymph nodes also.
No cervical lymph nodes also, sir.
You show the T2 or contrast.
Ma'am. This is a T2 weighted axial image. I'm going from superior to inferior. You can see a like mixed area of hyper intensity and hypo like bright and dark areas. We can see mixed signals are there.
Then you can see the entire.
Mainly it is T2 hyperintense, we can say. ISO to hyperintense.
Okay. So the MRI characteristics are in favor of benign.
Yes, sir. It's in favor of benign lesions.
It could be benign or low grade because the mixed intensity you can get in benign mucoepidermoid low grade also.
Yes.
So you can say because the capsule is intact, it is not a high grade, you can't see lymph node as well.
Yes. And there are no significant neck nodes.
Okay. Okay, then how will you proceed further?
Uh, as per the FNAC report, like I'd like to confirm my diagnosis with the FNAC. After the FNAC report is available, I'll proceed ahead with counseling the patient accordingly, sir.
Okay.
So in this case, USG guided FNAC is important because there are cystic areas as well as
Yes.
some solid areas.
Yes, ma'am.
Because varying intensity. So
Yes.
better to have a guided FNAC. So you have the FNAC report with you?
Yes, sir. FNAC report is low-grade salivary gland neoplasms.
Okay.
It was not specified, like what neoplasm histological type was not specified, sir.
Okay.
So what will you plan and how will you counsel the patient? And what will you counsel the patient about the surgery?
My plan will be to treat it with like surgery. My intent will be
Is there any other
curative.
option? Is
My
there any
intent,
other option?
no, sir, but my plan will be curative with the surgery, like curative intent, and modality will be surgical, sir. And
Okay.
I'll counsel the patient accordingly. Based on the information available with us, it looks like it is a benign lesion, and we'll proceed ahead with the superficial parotidectomy, which is the least amount of parotidectomy, like which is
What is
which
the
should be
TNM staging of this patient?
uh, sir. It is T1N0 if you're considering is low grade carcinoma, sir, low grade.
Yeah.
What is the size of the tumor?
It was 2 into 2 centimeters, sir.
See the MRI, it is 2.2 into 1.9 something. So it is
Okay.
more than 2.
T2.
T2. So only if you have suspecting malignancy, you say TNM. Otherwise, it's a benign, don't say
Yes,
TNM.
yes. If you're considering malignancy, then it will be T2,
T2
based on MRI reports.
findings. Okay.
And what will you counsel about this to the patient?
So
If
I'll counsel the patient that surgery is required for your condition, and there are certain complications related with the surgery, which will include facial nerve palsy, which may be temporary or
yes,
permanent.
when you are
Temporary.
when you are saying about the surgery, you should not say immediately after the surgery about the complication. You have to tell about the extent of surgery, what kind of surgery you are going to do, whether you are going to address neck or not, and what you are going to remove in the parotid. Then
Yes.
after the surgery and how you are going to reconstruct it, plus minus, if it is extended, means extending to skin or whatever. After that, you have to tell about the complication. If you tell immediately after the surgery about the complication, patient will go. Okay.
Yes, ma'am.
Okay.
So I'll tell the
So,
patient that will be proceeding and with the superficial parotidectomy will not be addressing neck, and in all probability, no adjuvant therapy will be required.
so that is the main utility of FNAC. You can
Yes.
better counsel the patient.
Yes.
Otherwise, even if it's a low grade or otherwise
Yes.
malignancy, the
Final decision regarding.
surgery is the treatment. So
Yes.
you can counsel the patient better if you have a cytology report of a benign disease. Okay.
Yes.
If it is a benign, sir, if there is no cancer, can you observe the swelling like that? For past 3 years, I am observing it is not increasing in size.
Ma'am, there is importance of like observation in tumors like what, not in this case, but in Warden's tumors where the patient is elderly. There is role of FNAC that if comes out to be Warden's tumor, since they are slow growing and no very low risk of malignant transformation, less than 1%. So those patients can be observed. But if it is a low grade carcinoma or pleomorphic adenoma, I'll counsel the patient that with time it is going to increase, and if it is benign like pleomorphic adenoma, which is most common, there is high chance of malignant transformation.
High
In that,
chance.
We will answer. I just want to know the percent. What percentage? Because you are getting educated patients in OPD, in your private OPDs, then he will ask how much chance of malignancy is there if I wait for 5 years or 10 years or 15 years.
according to a study, ma'am, there is a risk of I think 6% in 10 years malignant transformation.
Indraji, in your practice, how many cases you have seen pleomorphic adenoma turning malignant?
Like at RCC, I have seen 3 or 4 cases, sir. Like in 2 years, last 2 years, sir.
So
Okay, it's usually not that common, especially of
Yes.
this. But surgery is the treatment option
Yes.
because of the
With the time, it is going to increase.
potential for growth.
Yes.
And once the size increases, the complications of surgery is also be more.
Surgery will be more, sir. Yes.
you have to tell, even if it is pleomorphic adenoma, you have to get operated today or tomorrow. Better today, because as the size will increase, the complication will increase, and you don't know when it is going to convert into the carcinoma ex pleomorphic adenoma. And if you see the literature, then there is 9.6% risk if you wait for 15 years. If you wait for 5 years, the chances is less. It is 1.6 year.
Ma'am.
So you have to operate the pleomorphic adenoma.
Yes, ma'am.
So, what surgery you plan?
We're planning superficial parotidectomy for this patient, sir.
Superficial parotidectomy means?
So superficial parotidectomy means removing the parotid tissue superficial to the plane of facial nerve.
Okay, lateral to or superficial to
Lateral to or superficial.
If suppose it turns out to be intermediate mucoepidermoid carcinoma in final histopathology,
Yes, ma'am.
then the patient will ask, sir, did you complete, did the surgery was okay? Was that procedure okay? Or I need to, are you going to readdress the neck? Then what will you say? And whether I need the adjuvant radiation.
In intermediate grade mucoepidermoid carcinoma, radiation is an option, ma'am.
No, in other words, intermediate is clubbed with the low grade or high grade as per different guidelines.
It is clubbed with the high grade malignancy, sir. Like as far as I remember.
But you can check the ESCO. I think ESCO clubs it with the low grade.
So if you see ESCO, it club it with low grade, but if you see NCCN, then even after intermediate grade, you have to give adjuvant radiation.
Yes.
Thing is, while you are operating on low grade neoplasm, salivary neoplasm, you have to see level 2 lymph node also. If it is there, send the frozen, even if it is not there into the in the MRI, if you can't see, because you are opening till the neck, I mean till the level 2. So just a little more dissection you can see. If it is the node is there, you can send for frozen, and simultaneously you can address 2 to 4. Otherwise, even after that, if you give the adjuvant radiation, there is no study, comparative study, which says ENI is better than the elective neck dissection. If you see Chen study and Herman's study, but you have to address the neck. Okay.
Ma'am.
Okay. When will you do a total conservative parotidectomy for a swelling like this?
Sir, total conservative parotidectomy will be done when it is involving deep lobe, sir.
Okay.
Only in that scenario, or
what about if you suspect it's a high grade tumor?
Yes, if it is a high grade tumor also and facial nerve function is normal, like in this case, sir, will proceed with like T3, T4 high grade tumor will proceed with the yes.
And if the tumor comes close to the facial nerve also.
Yes.
So what is the role of any role for a frozen section for your margins or?
Sir, for margins, frozen section, like it has not been described like in, but if we are sending frozen section intra-op, there is a suspicious involvement of facial nerve. If you are going to like, in this case, it will not be required, but
Okay.
it has a frozen section as role in knowing the nature of lymph node in level 2, sir, so that accordingly neck dissection can be planned or not. And secondly, if you are sacrificing facial nerve, like we should confirm it before it is involving the facial nerve before sacrificing the nerve. And
With this, that facial nerve resection you will plan on the frozen section based on the frozen report. See, if patient has pre-op facial nerve palsy and
Yes.
during the intra-op, you cannot get the plane, fine dissection
Yes.
plane.
Yes,
Then,
ma'am. Like if the
and
yes.
the tumor is grossly involving the nerve, then you will resect that branch and you will reconstruct also.
Yes.
But based on frozen section, deciding upon the facial nerve is not justified. Frozen section is meant either the level 2 for the lymph node dissection or the extent of parotidectomy. Suppose you were thinking it is pleomorphic or low grade.
Yes, ma'am.
During intra-op, you are seeing that it looks like a high grade. Then
Yes, ma'am.
you want to see whether you are going to convert it into total conservative or you just want adequate or superficial parotidectomy.
Yes.
When will you do an elective neck dissection in parotid swelling? Clinically in zero.
Clinically, N0, sir, high grade tumors and T3, T4 tumors, and all adenoid cystic carcinoma, sir.
Why
And
No,
adenoid cystic carcinoma?
sorry,
adenoid cystic carcinoma usually won't involve
sir,
the neck
yes, sir.
nodes. Mainly,
Extraglandular
mainly
extension.
mucoepidermal carcinoma, high grade.
Yes, yes, sir.
Your answer should be very crystal clear. It should be high grade or N plus or T3, T4. That's it. Like, why do you want to do total conservative? Then your answer should be if it is high
T4.
grade or T3, T4.
Yes,
Why? Because the chances of lymphatic nodal intraparotid node metastasis is high. So you want to clear the nodal basin, parotid nodal basin. That's why you want to do the total conservative.
yes, ma'am.
Because if you see the margin, the literature, there is the paucity. The extent of resection, no one has described, but it should be negative. What is negative? What constitutes negative? The capsule should be intact and there should be some cuff of parotid tissue. See, superiorly and inferiorly you can get, but
Yes,
some superficial and in the deep aspect, you will not get the parotid tissue where the facial nerve is just as adjacent to it. So your parotid capsule should be intact and you get the plane with the facial nerve.
yes.
So what is special about adenoid cystic carcinoma of parotid?
Adenoid cystic carcinoma, sir, is a
Is it
high grade.
is it a low grade or high grade?
It is a high grade tumor as per WHO classification, sir.
What are the grading for adenoid cystic carcinoma? How do you define the grade?
I'm not sure, ma'am.
Spiro and purging Xanto. So it could be low, intermediate, and high grade. And there is one more thing, de-differentiated, high grade de-differentiation. You should know how
Yes,
to
ma'am.
do
That has been described in the latest WHO classification.
know how to
Dedifferentiation,
do solid as well as the high grade de-differentiated adenoid cystic.
ma'am.
Is there a what is the margin you want means in histopathology you'll be happy after doing parotid surgery?
Sir, in benign lesions, margin will not be an issue, and but if it is low grade carcinoma, sir, like medially when we are dissecting a facial nerve, even if it is close to like the margin is close there, like studies have indicated that it
Is
is
there any study which has looked into the margin of parotid or salivary gland tumor?
sir, I have read that it may still suffice in low grade cancers. That concept of margins all around, clear margins all around is not there, sir. Only if we have suspicion of margins, sir, like in superficial parotidectomy, if you are suspicious that we have not got an adequate margin, we can convert it to
What is
total.
adequate margin? That's what we wanted to know.
Sir, 5 millimeters, sir.
And the oral cavity margin that we cannot take it in the parotid. I think there is not much literature in this. You can see
Yes,
there
sir,
is a
there's no
paper in
literature. Yes, sir.
there is a paper from MSKCC. You can see that. I think they take 1 mm as a margin for parotid, but for minus ribosome gland, like the oral cavity, 5 mm.
Yes, sir. If it is in oral cavity, 5 minutes.
When will you resect facial nerve? Sacrifice facial nerve?
Sir, when it is preoperatively involved or intraoperatively, if you are seeing that it is the coursing through the tumor, and on a careful dissection also, if you are not able to get a clear plane between the parotid and between the facial nerve and the tumor, if there is any evidence of prefacial palsy from EMG, then we can sacrifice the facial nerve, sir.
Okay, even if you sacrifice, try to limit to the involved branch only. Selective
Yes.
sacrifice. Don't cut the trunk of the facial nerve.
Yes.
Okay. So when will you plan adjuvant treatment in parotid tumors? Post-op-RT?
Sir, T3, T4 lesions and high-grade tumors, intermediate and high-grade tumors, when there are lymph nodes, when there is perineural invasion, lymphovascular invasion, if it is there, clinically like N plus neck or positive or closed margin,
Okay.
then will be.
Invariably, in adenoid cystic carcinoma, irrespective of the stage, usually they plan post-op-RT.
Yes. Yes.
Then the other histologies based upon the stage and the nodal status.
Yes.
Okay, then regarding facial nerve, intraoperatively, inadvertently you have damaged the facial nerve or a main trunk is cut, then what is the options?
Sir, if the distance between the cut segment is less than 20 millimeters, sir, then primary anastomosis can be attempted after freeing the either end, sir, if it is possible, using 80 proline suture, sir, to suture the epineurium, sir.
Primary neurorrhaphy, whenever possible, a tension-free anastomosis. With the primary neurorrhaphy gives the best results. Okay.
Yes.
So if a segment of nerve is involved and you got the proximal and the distal stems, then what are the but you can't do a primary anastomosis, then what are the options?
So the usual choice is greater auricular nerve, which lies in the same field and can provide adequate length, sir. And secondly, sir, sural nerve can be used, sir.
Usually you do cable nerve graft.
It is cable nerve grafting.
Cable graft.
Or hypoglossal jump grafting, interposition grafting can be done.
That usually you do as a secondary procedure, nerve crossover and all. So
Sir.
primary, but even you do a cable nerve graft, that will take time for the recovery.
Yes, sir. It is usually takes like 4 to 6 months for the effect to start, and full recovery may take 1 to 2 years, sir.
So during that time, you should do active physiotherapy so that the facial muscles will not get atrophied.
Yes.
Okay.
For facial nerve reconstruction, it is a big, theory question you can get. When you have inadvertently damaged the nerve, you have to see whether you have damaged it at the proximal or at the distal. If you have damaged at the proximal, the branches upper and lower are separate and the proximal is separate. You cannot do the primary anastomosis. You have to do upper with the different and the lower with the different. You
Yes,
understand?
ma'am.
And
Yes,
if
ma'am.
you are getting one branch damaged, then you have to see whether it is a tension free. There is no mention of more than 2 centimeter or 1 centimeter. You have to see whether it is a tension free anastomosis or not. If it is not, then you have to put the cable graft. If it is 5 to 6 centimeter, then great auricular is okay. Otherwise, take pseudonym. And if you are getting, I mean, the two trunk different, upper and lower different, and the main trunk different, then what you have to do, either you connect lower trunk with the primary main trunk with the cable graft, and the upper trunk you can do anastomosis with the nerve to masseter. Okay, and it is
Ma'am.
very easy to see the nerve to masseter. You can take this probe is there with anesthetist. You can just see with the twitching, you can apply there, but everything you have to do under muscle sparing anesthesia.
Yes.
If it is like that, only one branch is cut and you are not seeing the proximal stump, or you are seeing the distal branches are cut, but the proximal stump is not there, then you can do the nerve transfer either with the hypoglossal or with the spinal accessory. Only the 40% end-to side you have to do. And if your margin is positive at the primary trunk, then you have to drill the mastoid. So the different kind of questions you can get on the facial. So these all are the dynamic which you are doing the intro. When someone else has done the surgery outside and the patient is coming to you later on, then you have to see how much is the duration. Based on that, you can do the static. And regarding the margin, if you see, never tell about, for the major salivary gland, never tell about the margin in the means measurement, 5 mm or 2 mm. So where it is mentioned. So if you see the study of Zenga and Stodulsky, they say narrow margin, even between 1 to 2, whatever the margin is, but the capsule is
The deeper plane over the facial nerve, you may not get 5 mm, just like in oral cancer or anything.
Yes.
Yes.
Yes. Yes.
Okay, then the anatomical landmarks, surgical steps, everything should be confident.
Yes.
Okay, I think almost 1 hour.
Then read about the Schmidt's meta-analysis about the FNAC and core biopsy, complication of core biopsy, and what else adjuvant radiation has been covered. Next is the metastasis. If you, in adenoid cystic case, if you get suppose the Viva case on adenoid cystic with the lung metastasis or with the bone metastasis, then you should be ready. How will you treat that? What will you do? Sometimes we see it is not very uncommon. We see in our private OPD adenoid cystic carcinoma with lung metastasis or with lung as well as with the bone metastasis.
So what is the role of metastectomy in adenoid cystic carcinoma? A patient after 3 years after surgery comes with a single solitary mets in the lung.
Sir, if it is resectable, sir, and the period is less than 36 months, then we can go ahead with the metastasectomy, sir.
You have to see the location. If it is centrally located, you cannot do. You have to cut the pulmonary artery. You cannot cut the pulmonary artery. If it is at the peripheral location, you can do wedge excision of the lobe or wedge excision of the lesion, taking 1 to 2 mm margin, or sublobar anatomic resection. So you have to see the location as well as the number.
Yes. It is, if it is less than 5 number. I think.
Sir has mentioned it is 1. So you have to see only the solitary met, but where it is, whether it is at the center or at the periphery.
Adenoid cystic carcinoma is just like thyroid carcinoma. Even with mets, patient will survive for years.
Yes.
And most of these patients over the time, even limited adenoid cystic carcinoma, you have seen after 10 years coming with pulmonary mets. Okay, then read about the targeted agents, newer agents, molecular markers. Okay. Okay, Indranit, you presented well. All the best.
Thank you, sir.
All the best, Indrajit.
Thank you, ma'am.
Indrajit, you presented really well. And thank you all the moderators for this discussion. It will surely help all the residents, all the exam going residents. So we'll meet again next time. Our next Mahamani case discussion series will be on November 13th. It will be on carcinoma unknown primary. So see you soon. Thank you.
Thank you.
Thank you.
Thank you, sir.